My first two cases as a resident were PC rents. And that was the day I decided that I should not be scared of PC rents. So, so these are the case scenarios that we would be discussing. Case one would be a PCR with the entire nucleus in the bag, and that's what we don't want, a nucleus drop. Case 2 would be a PCR, a toric IOL is planned. Case 3 is 1/4 PC support absent and a toric PC IOL is planned. And case 4 is a small pupil and I have a PCR with the nucleus in there. So this is one of my fellows who's doing it, and he or she, I thought that, okay, no, let me take over, and this is what I have done, not the fellow. And I have a rent out there, and I don't know how big. So I use a dispersive viscoelastic without shutting off the irrigation, and now assess the situation. My CCC is intact, that's for sure. And like Dr. Vavikar was telling, you should get all these fragments into the anterior chamber shelf and keep the fragments in the area which you feel that the PC is intact there itself. Don't get them, all of them out there, because then it's going to cause more turbulence. And then slowly, after decreasing your parameters, you can actually, if you've seen, my normal aspiration is 26, I've dropped down to 20. My vacuum is 550, I've dropped down to 400. And I remove off all the pieces one by one. So this is something which I got adventurous after listening to seeing Osher's video, which said that the vitreous is a scaffold, and if the vitreous is formed, it's not going to allow the nucleus to drop down unless you churn it. And you churn it only by having higher fluidics. So the most important thing out here is to decrease your fluid that's going in and out. Drop down your flow rates, drop down your bottle ride, drop down your vacuum. So after doing a staining with triamcinolone, this is the vitrectomy which is being done. What I'm showing is the use of alternate between IA cut and cut IA as a vitrectomy. So this is a very important mode that you should be using in your vitrectomy, in which you can use it as an IA thing as well, and sometimes you can use it to cut. So you should be toggling between the two modes. Now, because the PCR is very big, it's like half the PC gone. I'm not going to attempt to put anything in the bag. This is a 3-piece IOL which is being put in the sulcus. A way of putting the 3-piece IOL is to have the bevel up on the left side and then slowly rotate it so that the haptic opens up in the plane of the iris. Now you dial it in, and I usually like to keep my rexes at around 5.5 mm, so I'm able to do a posterior optic capture in this patient as well. And it sits very well. And this is going to center and be centered perfectly because it has adequate support. Form the chamber at all times, see to it that the chamber does not collapse and become soft. Like Dr. Nagwekar, even I like to do a rigorous PC polishing, but if I don't check the edges of my bimanuals, this is what I get sometimes. Fortunately, there is no vitreous tag which is there. I have put a dispersive viscoelastic. This is a small technique you should master because many a times the flap tends to go into the vitreous and it's difficult to hold it. So you may use a second instrument to do assisted PCCC and complete the PCCC out here. And because this patient was for a toric IOL, I could end up putting in a toric IOL and it's a happy story. Now here the most important thing again is try to decrease the manipulation of the IOLs. And when you're trying to remove the viscoelastic from behind the IOL, see to it that your chamber is very well formed and your aspiration is low. Because if at that time your aspiration increases, you tend to churn up the vitreous and the vitreous will start popping in from the PCCC. It's not difficult to manage that, but you'll have to end up doing a vitrectomy again. Now here I have a big triangular rent. It's like a quadrant gone. Now definitely I'm in a soup and I have a toric IOL to put. I'm trying to do a PCCC. It's going in the periphery. So this is something that now I am not doing this. So now I take a deep breath, pause, and now I think, what am I going to do? So I say, let's try this. If not, then I'll have to explant it. So I put the IOL in the area which is intact first. The haptics go in. My IOL gets placed in the axis. And I attempt to do an anterior optic capture for this. So now once I'm sure that that area in which the haptic is gone is the area where the equator is, now I have shifted the entire IOL into the axis. So the important part is the knuckle should go into the equator because there still is some support out there and you want the haptic to be there and the optic is to be held in front of the rexis any which ways. And it's perfectly sitting well, stable. Tap on it, see, do the trampoline test. Now we have this case number 4. I had operated his first eye, small pupil, and I was confident, oh, went very well, not going to happen. Let me not put any pupil expander. And I'm going very confidently, ho raha hai, sab ho raha hai. And now suddenly I feel a giveaway and there's a surge out there and some part of the nucleus start tilting. So I slow down. No. Something is wrong there again. And I'm not able to see the PC here. There's the surge. So I increase. The pieces are starting to come up now here. Luckily, because of the low fluidics, I'm able to not drop the nucleus fragments down. I'm getting them into the iris shelf with the bimanual technique. So I'm using a iris hook in one hand and a round iris spatula in the other. And I'm checking at the same time whether my rexis is intact. So whether it's a rexis tear which has gone behind or whether it's a PCR independently. And now the pupil also has started coming down. Now, unfortunately, with small pupils, even if you do use phenocaine or any dilating agents intracamerally, they are not going to give you a full dilatation once the meiosis starts. So you're not going to be able to see your rexis margins if it's around 5 mm or 6 mm. So here I put a Malugin ring after I have done all the manipulations so that I can see where the rent is and manage the rent, where I can see the rexis margins and manage the rexis, manage the IOL placement. So again here half my PC is gone, so he was planned for a toric IOL. So we had to do with a 3-piece IOL in the sulcus. So this is the use of the eye cut mode of the vitrectomy, which is a good mode to use whenever you have PC rents. And there we are putting the IOL in the back and we would do a reverse optic capture for the same IOL. I'm done. I'm perfectly done. It's just I'll just wrap it up. So to summarize, we need to have dispersive viscoelastics, slow-mo phaco with lower fluidics, microrhexis forceps ready. You need to convert to a PCC whenever you get a rent. Don't wait for it to increase. Vitrectomy is always kept ready. You need to use both the parts of the vitrectomy, the IA cut and the cut IA. That's very important. Keep pupil expanders ready in your OR. CCC, try to put it at 5 to 5.5 and always have a library of 3-piece lenses. डर के आगे जीत है.